Okay.
We got it.
Well, you know, as I said a little earlier, there's no commercial bias in this. This is just a discussion about how we got to the point we are at now, where we're doing a lot in the way of lateral spine surgery that, you know, we might have adapted earlier, but because of a few reasons, we didn't. And I'm just going to talk about some of that now, okay? So, you know, when you think about spine surgery, you have to recall that, like, the anterior column and the middle column of the lumbar spine, they are about 80% of the biomechanical load of the spine, whereas the posterior elements, or the, you know, the posterior column, bears only about 20% of the weight of the spine in an adult. And so the question is, you know, what does the retroperitoneal and the transpsoas approach offer that an anterior or a posterior approach to the lumbar spine doesn't offer? And when you think about lumbar spine surgery, you often think of the type of surgery that Mixter and Barr did in 1934 on the first lumbar disc surgery. Mixter was a neurosurgeon and Barr was the orthopod. So the anterior approach to the lumbar spine really didn't get popular, I think, until people like John Kostwick and Kiyoshi Kaneda began doing a lot of anterior lumbar spine surgery that Dr. Kostwick got involved with when he was doing a lot of the trauma at the University of Toronto in the 70s and 80s. So the anterior lumbar spine approach in the United States, it's usually done with a exposure surgeon who can be often a general surgeon, a vascular surgeon, and sometimes a urologist, anybody in the peritoneum a lot that's comfortable working there. That helps the spine surgeon, be him an orthopod or a neurosurgeon. In Europe, you know, people like Dr. Harms or Dr. Mayer, they do so much. They've done so much trauma. They're frequently very comfortable doing the exposure themselves. So the problem with the approach anteriorly is that, you know, it is a pretty invasive approach, but it can be done through smaller and smaller incisions now. But, you know, it certainly requires an overnight stay in the hospital at least. It's usually more than that. It's usually several days. The posterior approach, as we said, is really the most common approach to the lumbar spine, but that's a very heavily muscled area, and until recently, it's required a lot of extirpation of muscle. Even if you're doing a relatively small approach, the splitting of the muscle is problematic and painful. But in some respects, there's people that have worked on overcoming that. We'll talk about that in a minute. So why the lateral approach? Well, when you think of the lateral approach, it's a small incision, maybe 3 or 4 centimeters over the flank, just maybe above, in the mid-axillary line, just, you know, a few centimeters above the iliac crest, depending on where you need to be in the lumbar spine. And the beauty of the lateral approach to the lumbar spine, which is, as we'll define it now, retroperitoneal and across the psoas or by retracting the psoas muscle is a really direct approach, and the structures between the spine and the skin are highly mobile structures. So when you have the patient in, say, a right lateral decubitus position where the right side is down, the left side is up, and you're making the approach there, it's a small incision, and it makes a lot of anatomic sense. The muscles you cut through, the muscles you divide are clearly visible. You open up and you see the external oblique and the fibers run in one direction. And I have some images for you, so don't worry about visualizing it. But you have the external obliques, then you get down to the internal obliques, which are clearly defined. Then as you get below the internal obliques, you have the transversus abdominis, which again, the grain of the muscle runs in a different direction. You see it. And once you split that, you're in the retroperitoneum. And you can look directly at the spine then, and what you see is the psoas muscle and some disc. It's a beautiful approach, and there's usually like no blood loss at all for that approach. So the question is, when I first saw it, I thought, boy, I wish I had thought of this earlier. Like I really was, it puzzled me that nobody thought of this sooner. And so, I think of that joke about you have two economists, two professors walking along the street, and the one economist turns to the other and says, hey, there's a $20 bill there on the ground. And the other economist turns to him and says, that's ridiculous. If there was a $20 bill there, somebody would have already picked it up. And they just keep walking. And that's what I thought about this retroperitoneal approach, because I had seen it a while ago, and that's what I want to tell you about. Mm-hmm. So again, the retroperitoneal approach is to do what's called a lumbar interbody fusion. And usually when you talk about lifts, lumbar interbody fusions, three operations come to mind. One is the A-lift, the anterior lumbar interbody fusion, which is through an incision through the abdomen. And in the United States, we use an approach surgeon, and in Europe, frequently a lot of the orthopods with a lot of trauma experience have done so many of the approaches on their own that they do it without an approach surgeon. So it's just regional differences. But it can be a bigger operation, and there are some risks to it. The approach is called a posterior lumbar interbody fusion. And really the first champion of the lumbar interbody fusion was none other than Ralph Cloward. And, he did these operations, in the 40s. And for a long time in the Philadelphia area, there was a very good surgeon named Paul Lynn, who was at Shriners and Temple University, and he was a big proponent of the posterior lumbar interbody fusions as well. Now, Dr. Branch, Charles Branch Jr., the chairman of neurosurgery at Bowman Gray now, his father's a professor of neurosurgery. I think he was at Galveston, and his father was a very big proponent of the posterior lumbar interbody fusion, or PLIF, for years. And Cloward and Dr. Brandt Sr. and a few other people around the country came, stayed very interested in this operation even when it was really far out of favor. One of the reasons it fell far out of favor was that it was a pretty difficult approach, and there was a lot of scarring of the dura that developed, and there were issues with it that have really been refined now with microsurgical techniques and the excellent retractors we have now. And then in the 80s, Dr. Harms, Jürgen Harms, developed the transforaminal TF lift. So the T lift was something that Dr. Harms came up with, and that's a really elegant approach to doing the lumbar interbody fusion as well. But it is very similar to, it's not a clearly posterior approach. It's a few centimeters off of midline, but it still requires some splitting of the muscles, or the muscles aren't necessarily cut. Now, the T-lift really got further evolved by people like Dr. Steve Ritland in Arizona, who has this really elegant approach to the T-lift, where he just carefully splits muscle groups, and he's done an incredible job. He hired an artist, and they did all these diagrams and MRI studies and just artwork of the inner lumbar area musculature. And this is really well outlined in an article that appeared in Neurosurgery with Dr. Ritland on it, that Dr. Benzel called a real gem in terms of surgical approach anatomy. It's very, very elegant. But Dr. Ritland found ways to split the muscle so nicely that people were relatively pain-free, and he would do these T-lifts on a basically outpatient basis. So the lateral approach makes sense because it's a very nice trajectory to an area where the organs are highly mobile. So everything came down to anatomy, and like I said before, Dr. Ritland did a lot to lay out the anatomy of the iliolumbar muscles and all the ligamentous attachments there that he encountered through these small incisions. There's a lot of nuances to the way Dr. Ritland would do the surgery, and he designed a lot of different speculums that worked really well for that, and he had one commercial system out that did okay, but it took some learning. The thing about the lateral approach was that not many people had done it that I knew of. And I first came across it in 1996 when Dr. David Polly and Pete Clara and the nurse Jean Evans, who organizes the meeting, would have a spine meeting in Bethesda, Maryland, at the Uniformed Services Hospital. It was a big cadaver lab, and a lot of people attended these dissections and that were interested in spine surgery, and a lot of good people came out of that. In '96, a lot of people were very interested in pedicle screws, and a lot of people were. During the pedicle screw session, the tables were packed, but I ended up at a table where the cadaver was in a lateral position, and Dr. Charles Ray was there. This is before the Ray cage had come out. And there was a German instructor there, and Esculap, the company Esculap, had this really elaborate system, retractor system, for exposing the lumbar spine through a lateral position. And then we were taken through a dissection on how to get there. And it seemed so obvious that this was a good approach. I just wondered why I'd never had seen it before. And that's what reminded me of that joke with the economists. Like, there couldn't possibly be a $20 bill there because somebody would have already picked it up. So the problem was that you didn't have really a way to monitor the nerves, especially at the 4-5 level, and that is the level where the femoral nerve often traverses the disc at the L4-5 disc space. And a femoral nerve injury can cause paralysis of the quadriceps muscle, which can make give somebody an unstable knee, and they can't walk. It's a much bigger problem than say a transient foot drop, because the person can't walk. So, that was a troubling part of the operation that you just didn't know about. But the next year, I talked to a few people that were at the table, a group of orthopods. They're from the Northwest, and they said, they had gone home and did the approach, and it worked great. And the thing about the retractor system, and Esculap used to advertise it as the mini APOS or something. It was an acronym that really didn't make sense in English, but it did in German. But it was so well thought out by Dr. Mayer, who designed the operation. There were just so many moving parts and attachments that it was kind of bewildering and kind of intimidating. And this is actually, this is 1997 now. So I got back involved with the lateral surgery when a company here in the U.S. did a good job of marketing how well to monitor for the L4-5 level. And then there was a return of interest to lateral spine surgery, and now it's a very big topic and very popular approach. And people like Juan Uribe, who's at USF in Tampa, and Dr. Bill Smith in Las Vegas, and Dr. Luis Pimenta is in Brazil, have done a lot of great work. And so Dr. Uribe and his residents and Dr. Vale, one of his colleagues, they did some really great studies on the position of areas of lumbar plexus to beware of, and it made the operation much more safer and reproducible. Now we're at a point now where patients, surgeons like Dr. Uribe, Dr. Smith, Pimenta, and people from all over the place, I'm failing to mention lots of people, refined everything, and as you visited different places, you picked up different pearls wherever you were. I, for instance, still use a second incision that I like to use to feel when I'm on top of the spine. So when I pass a cannula down, I can dock it on my finger and then gently put it onto the spine by retracting the psoas muscle with my finger. But there are so many different techniques that now we have all these systems, and we've come full circle because every company has a system now, and I'm trying to avoid mentioning company names, but it's just like when Dr. Mayer first designed this, the first system. There's so many different retractors, instruments, speculums, angled retractors. There's different ways to anchor on the anatomy, be it bone or be it on the disc space itself. There are shallow docking systems which were designed for kind of defining the femoral nerve before you docked on the psoas. As I mentioned, there are different incision types, and I think we're going to see lots more things in the near future. We're going to see expandable cages that you can backfill with a fluid-like bone substitute. I think we're going to see from the scoliosis surgeon more asymmetric cages that will help with deformity, and we're going to see angled. We're seeing angled instruments for people that have a high iliac crest. So I think the advent of the one company who really championed it for electrophysiologic monitoring is the thing that really got everybody's attention to lateral spine surgery. And when you talk to most people about the lateral spine surgery, they'll tell you all about Dr. Pimenta, Bill Smith, all the different people in the area that, in the world, that do the surgery. In Florida, there's not only Dr. Uribe, but Dr. Fazel Zawari in its Celebration Hospital in Orlando. I've visited him and watched him. He has great little pearls of how to remove the, how to do your anterior releases of the lateral side. And, you know, by visiting all these different places and seeing all these different surgeons with different techniques, there's lots of ways to do it, but I think it was the ability to monitor for the femoral nerve that made people more confident to do the surgery. But Dr. Uribe advanced things a lot because he noted that when these femoral nerve injuries occurred, and they usually are transient, that there usually was no electrophysiologic warning. And that was really, I think, because it wasn't a failure of the monitoring system, it was more a failure that we didn't recognize it. Sometimes there would be aberrant branches, and you know, the monitoring system wasn't going to pick that up. You had to know the anatomy. So that's what I think brought more people into the fold of doing a lateral approach. But I kept thinking back to the time in Bethesda, and Dr. Mayer's first article about lateral approaches to the lumbar spine actually came out in the March 15th edition of Spine in 1977. This is the first article. And actually, the article was first acknowledged for acceptance in 1995. So that's almost a full decade before the many other companies got into the lateral approach. So the article is called New Microsurgical Technique for Minimally Invasive Anterior Lumbar Interbody Fusion Technique. Now, if you remember, Spine in the 80s and 90s was always a black and white journal. It was always what a colleague of mine called a how-to, not a who-to journal. But this, in fact, was a technique journal, and Michael Mayer wrote it, and it was the first article I'd ever seen in Spine with all these color pictures and diagrams, and like I said, it was a technique article. So I think even though that so many people made big contributions, I kind of want to acknowledge that Dr. Mayer, the orthopedic surgeon from the Free University of Berlin, he really is, to my knowledge, the first person that ever published on this. But he's in some ways forgotten. Now, I might be wrong in that when I talked about this with Dr. Zawari, he said that he thought actually Paul McAfee may have published something even before the 97 article, but I don't know about that. But it's like many things in medicine or anything in science, really. You know, sometimes things develop emerge at the same time through different discoverers, like calculus and Leibniz or whatever. But you know, clearly Mayer had an early start in this, so I think that he shouldn't get, be left out of the discussion. So that's about all I've got in the way of slides, but I do have the article, and if you have any questions or you want any bibliography or the links to these articles, I can get them for you. But it's just interesting how the field developed and how so many companies have designed just so many systems now. It's really very interesting.
Well,
that's really about it for the lumbar approach.
okay.
But all the visuals in Dr. Mayer's article are color diagrams that he had the artwork done for. I didn't get permission to show them, and so, like I said, I have the article, and if you want the bibliography information, I'm happy to email that to you.
Sure. Okay, thanks, Richard, for a great talk. One thing that, before I ask the panel if they have any questions, one thing that strikes me when you're talking is that a neurosurgeon kind of doesn't have to, but it helps to have an engineering and a mechanical background to judge the best approach. And certainly experimenting with different approaches seems to be a good thing to do. Now, one quick question that I have, what do you cut through some major muscle groups going in the lateral approach?
Actually, that's why I'd like you guys to look at the article. Actually, you cut almost nothing.
Okay.
You cut the skin, and I actually, and this is, I actually use a second incision for my finger so that after I cut through the skin and I pass a catheter or I pass a guide through the skin, I put it on my finger, and then with my finger I pull the psoas muscle back, put it right on the disc. Like I could feel the disc when I put it on the disc. So I like that extra tactile feel. But this is not at all a painful operation.
Okay.
Now, in terms of cutting muscle, most of the guys these days really have tried to avoid splitting, cutting muscle by actually just retracting or dividing muscle rather than cutting it.
Right.
The problem with a direct posterior approach to the spine is you do have to detach some of the muscle off the spinous process. But that's one of the arguments Dr. Harms used to use for his kind of lateral approach to the lumbar spine from a few centimeters off, because he would go in between the muscle planes and split them just with his finger, and you could dissect right down to it. And a lot of guys do that now. Steve Ritten's really taken it to a whole nother level when it comes to just not atraumatically dividing the muscles. And the diagrams he uses in his talks are beautiful.
Mm-hmm. Very good. Okay. Any questions from the panelists of Dr. Mendel? Ben?
So, Dr. Richard, thank you very much for talking about the approach to the spinal surgery. I'm just wondering, so you think lateral approach is the safest approach, and so that you don't have to cut the muscles and you don't have to. I'm just wondering, while approaching the lateral way, do you come across any vessels or nerves, that kind of risk? I know it's safe for the muscles.
Yeah, well, no, that's a good question. I don't want to say that it's the best approach. What you have are several good approaches, be it anterior, the posterior variant, whether they're direct posterior or a little off center. This is what I would call direct lateral. The direct lateral, the anterior, and the posterior approaches all have their pros and cons. And, the L4-5 level, to me, is the level where there's often the most problems when it comes to your average adult male or female. And the L4-5 level is amenable to lateral surgery, but there's the risk of the femoral nerve. At almost any other level, there's no risk. You can't get to the L5-S1 disc usually from this approach. So when Dr. Mayer did his original study, he talked about it being a technique article, and he introduced two techniques. One was the lateral approach for L4-5 and up in the lumbar spine. and that was the retroperitoneal technique. But he also published the transperitoneal approach, and that was designed for the L5S1 level. And actually, you'll get a much better idea, a much better gestalt of this whole thing when you look at Dr. Mayer's article. The color diagrams are great. You know, to get to 5-1, you have to use a transperitoneal approach, and that's a drawback. So if you're in clinic and you have a person that's got L4-5 and 5-1 disease, you may say to yourself, well, I think it would be more comfortable for the patient to have the L4-5 level done, but if we're already going to do 5-1 from behind with a T-lift, we might as well do 4-5 from the same approach and get both levels done. Otherwise, you would have to flip the patient. You know, so there are trade-offs, and no approach is perfect. You know, there's going to be trade-offs, like any approach. Your approach is what gives you the best exposure and is what causes the patient the least amount of risk, you know. So I think the lateral approach is a great approach. There are no big vessels in the area. Okay. But you know what? That's stupid to say.
But what about plexus?
For me, I don't think of there being big vessels. But the truth is, the aorta and vena cava aren't far away. But they're when you're doing this kind of surgery, you're looking directly at the disc space. So, yeah, if you were bewildered and didn't know your anatomy, the aorta and vena cava are right nearby. But it would be hard to imagine that you could get that lost there. Okay. That's one of the things that as you train on doing the operation and on the cadavers, you're always keeping in mind where the anterior longitudinal ligament is at the front of the spine, and you see that, and you try to kind of identify that in surgery, so you know you never have to be in front of that. And I actually, before I start the operation, I mark the skin at where the disc space is at L4-5. I mark the margin of the front of the spine, the margin of the back of the spine. So it's really a very safe operation from a vascular standpoint. And I think because of Dr. Uribe's publications, I think it's a lot more safe in terms of avoiding a neurologic injury like ephemeral nerve palsy. But there is what's called the lateral femoral cutaneous nerve, and that often can run very high up near the skin level even, and if you injure that, you can give the person a lot of lateral numbness on the side of their thigh. But that doesn't happen all that often. However, almost every patient that gets this operation will have a big area of denervation for skin sensation and fine touch on the thigh for at least a few weeks. But I find that almost all the time. And it's self-limiting.
Okay. Eleonora, do you have a question?
Yes, John. Thank you, Dr. Mendel, because this is a new technique, so I didn't know about this technique. And I have a question. Do all the patients with lumbar pain are candidates to this technique, or some of them are ruled out because of, I don't know, because of some problems, or some pathological conditions are ruled out, so you cannot apply this lateral approach?
Well, you know, you bring up a very good point with the indication for the operation, and you know, I was discussing with you some of the kind of nuances of why you do a lateral approach, and I probably wasn't clear enough in the beginning to say that, you know, your choice of who to operate on is almost always the hardest choice, is deciding who you're going to help and who you're not going to help. You know, this isn't the kind of operation you do for simple back pain. I don't think you do any kind of operation for simple back pain if it's not due to instability. I think that very few things work for isolated back pain. I think if you are worried about, this is actually a great question, because when you think about elective procedures for discomfort, you're thinking about lumbar radiculopathies, you're thinking about claudication type of symptoms, and all kinds of things. And you have to think of those patients just as you would for any other, whether it was an anterior approach or lateral approach, posterior approach. You have to think about what the limitations are for the surgery. Now, the really nice thing about this procedure is that it's kind of evolved in all different groups of doctors that do spine surgery at once. A lot of the orthopedic deformity surgeons that pioneered pediatric scoliosis, like Dr. Mundis, who's now with Dr. Barney's group in San Diego. They are doing the lateral approach for children with scoliosis. It's great for deformity. It works very well in trauma. I've done some thoracic and lumbar cases like this for trauma. You see degenerative spine surgeons like Dr. Smith in Las Vegas, who not only did them for just degenerative disease, but Dr. Smith was using this operation for I saw him do an intradural meningioma with this approach once. I think it's a video that he's shown many times. I bet you could find that. So in all the different subgroups, the scoliosis guys, the degenerative guys, the trauma people, they've all seemed to gravitate towards the lateral approach recently. And so I think it's a good approach, but you have to be very comfortable with your patient selection first about what you think you can do with the operation. Because usually, a younger surgeon thinks they can cure all kinds of things that as you get old, you realize you can't cure. If you've been in the neurology department, I'm sure you've seen the string of patients come through with back pain and this pain. It may not be the most esoteric thing that's as interesting as, a Kluver-Bucy syndrome, but back pain and leg pain is a common thing that occurs commonly, and surgery is not the answer for a huge part of it.
I agree.
Yeah. So that was a good question, though. All right. I could have given you a more concise answer, I think. All right. I just think it's funny that we study all these things, we're thinking about all these things. Then one day you can see an approach you've never seen before, you've never heard of before. Then you don't hear about it again for another decade, and then everybody's doing it. It's kind of funny, just it's like the $20 bill that wasn't there. So,
Simon, do you have a question?
Yes, please. Dr. Mendel, this may be a very basic question. I'm only in my second year, and I'm basically just, studying the anatomy and trying to memorize the lumbar plexus, the brachial plexus, and all of the nerves and muscles, and hearing you talk about how the surgeon has to be very aware of where everything is sounds very scary to me. I'm wondering, when a doctor is a first-year resident in neurosurgery, how fast would they be able to learn the anatomy? How quickly does that pick up?
Listen, there are some people that are great anatomists. Very few people, though, know everything. There's Mike O'Connor, who was at the University of Pennsylvania. He's a brilliant guy, but when I was an intern, once in a while he'd do operations, and he would bring an anatomy textbook into the room. And I was surprised, and he said, "Look, when I'm in the car driving, sometimes I bring a map because I'm not in these places very often." That's why
I see. Okay.
So he was a guy that was willing to admit that. But you know what? Yeah. Most people aren't willing to admit that. So when you say, "Oh, it may be a basic question. They're all basic questions if you know the answer. It's knowing how to find the answer. So the thing was, that's what Dr. Uribe sorted out, because none of the neurosurgeons were that familiar with the branches of the lumbar plexus. I don't think yet many people understood that how consistently the femoral nerve ran across 4 or 5 disc space so consistently. It was when somebody looked at it and said, hey, these are the variants of the anatomy. This is how to make it safer. Uribe made it safer for everybody because everybody looked at it, and then nobody wanted to admit to their medical students they didn't already know the anatomy. So we lead you to believe that everybody knows it, but we didn't. We didn't understand it that well. So that's a good question. Now, the same thing happened with Steve Ritland. Dr. Ritland, you know, if you look at the anatomy of the lumbar spine posteriorly, the person that gets quoted the most is Nikolai Bogduk from Australia, who studies, you know, the anatomy of the lumbar spine, biomechanics of the lumbar spine. But, you know, very few spine surgeons really know the names of all the intra-articular ligaments around the spine, and, you know, they'll say this, the iliopsoas, the lumbricalis, whatever. But it was Steve Ritland that went and did all the fine cuts through the superficial layers of the muscle and had all the artwork done. So Ritland was able to detach small ligaments. He knew how to get from point A to point B by going around rather than through a ligament or muscle. And that's why he would do these operations and send people home 2 hours later. It's the importance of looking at the topography of the small area that you're operating in. As a medical student, you learn about all the really important things. And you know the brachial plexus inside and out. But you may not know the lumbar or sacral plexus nearly as well. But if you're a urologist, you certainly learn it. So as you specialize in different areas, you pick up the essentials of anatomy you need for that area. The key is to not stop learning about it. You got to keep learning about it. I really always like this approach, so I visited pretty much everybody I know who's famous in doing the approach. Pierce Nunley was an old friend of mine from LSU. You know, I've talked to him about it. I see Zawar. I've seen everybody do the approach. So the way I do it, not that I'm anyone to copy, but the way I do it's a combination of 40 different things these people have told me that I think is important, but nobody else may think so. You know, you just need a rationale for what you're doing. That's all.
Thank you. You know, Doc, there's always anomalies, but one thing in cardiothoracic surgery now, they're 3D printing models of infants' heart before the surgery, so they have a pretty accurate picture of the vasculature of a child's cardiac vessels. And they have a model of it before they crack the chest. Is any of that kind of going on with your area of surgery?
Yeah, it's being done now. The group, Dr. Spetzer's group, does a 3D printing of brain tumors before resections and aneurysms. And yeah, that's you know, it's a whole new world.
It's like an exciting area of medicine.
Yeah. So the thing is, no matter what kind of surgeon you are, you need to know the anatomy that you're working in every day. You know how to get around your neighborhood really well. But you may not know the territory that well once you're far out of your neighborhood. That's why you always want to keep a map. Now, having said that, you know, I think as good as all this technology is, having navigation or image-guided surgery is virtually useless unless you already know the anatomy. Having image-guided surgery won't make up if you don't know the anatomy. If you know the anatomy, it'll really, really help you. But if you don't know the anatomy to begin with, you're not going to learn it. You're not going to learn it by
studying a heart. Okay, very good.
Dr. Mendel, I have one last question.
Okay.
You mentioned these three approaches: transabdominal or anterior, lateral, and the posterior. So, I mean, if you talk about the companies coming with all these equipment and stuff, which one, which approach they're competing like?
You know what? The commercial companies, when it comes to lateral surgery, I think this is one of the few times where capitalism proved itself.
Oh.
And actually, the corporate industry sponsors poured money into the research, and good research got done. And I don't know of any systems right now that I don't think are good. I think all of them are really at least good. Some are terrific. But again, the nuance of the surgery, it's a matter of preference. But I think that there are a lot of people involved. There are a lot of systems now, which isn't bad. It's just that in spine surgery itself, you may have 100, 150, 200 different companies making cervical plates. And, it's good to have competition, but I don't know that you need 200 different plates, So,
Yeah, thank you.
Sure.
Thank you very much, Ahmed.
Okay, Simon and Eleonora, any last questions?
No, thank you.
No, thank you.
Okay, great. We won't keep it too long, Dr. Mendel. Thank you very much for taking the time.
Thank you.
Thank you, Dr. Mendel.
Out of your busy day. And I hope you come back. You raised so many good topics. You could be a neurosurgery historian, I think.
Yeah, I think
what's going on?
Stereotactic soon. That would be good.
Okay, well, we'll keep in touch, Doc, and thank you very much.
Sure. Bye-bye.
And I'll send you the link.
Bye, thank you.
All right, great.
Thank you.
Bye-bye.